And I think it is time to stop the experiment. We've experimented for a long time with the health of the people. It's in this country where we are having questions of affordability of health being a real issue that we're discussing, whereas health is a right, which means you get sick, or even before you get sick, you need to walk into a hospital and get treated without being asked for a cent. I've spoken here before about the infrastructure of SHA, which should not be as it is. It should have shifted into something else, and which I've always said that we should have living high-risk consumables, and let those high-risk consumables fund SHA, so that as we buy, because a free market, let that free market sustain itself, okay? Now that's one. Two, we have the problem of the systems. And how I look at it is this way. I strongly believe that results come from a system. They don't come from individuals. Now, when you're talking about an established republic like Kenya, Kenya has a system that works, or that should work. And that system, if it doesn't work because we are a democracy which keeps on experimenting with laws and trying to see what works and what doesn't work, then it's time to correct that system in its entirety. And that system looks like this. The biggest challenge that Dr. Miskela here will tell us with health now is the question of human resource. If you walk across these 47 counties, and even when I got the poster yesterday, I shared it on my Facebook page and asked them, what do you think? Should it be reverted back to the national government? And a chair of health in one of these counties has told me, there's public comment, has told me, I am the chair of the health committee in the assembly, and I want this thing reverted to the national government. Counties cannot manage it. Okay? From my standpoint, and that is as the CEO of Chronic Disease Society of Africa, I look at it this way, that there are bits of health which can be handled by the county, but there are bits which cannot be handled by the county because of these following reasons. One, we have the question of political goodwill. We have the question of patronage at the counties. These doctors are people who are equally learned, just as we journalists are very learned, of course. But the question that happens there is that doctors are treated, and generally the healthcare workers are treated political patronage. You have to earn the goodwill of a governor and his minions. And most of the times, these minions do not understand what health is, because 67% of the CECs who are chaperoning health in this country do not understand what pharmaceutical policies, for example, are. They're just seated there, appointed to oversee. You're overseeing something you don't understand. One, okay? Two, as he's saying, chief officers in most of these counties, some of them are doing very well, do not also understand why they are there. Because they're there to politic, they're not there to lead. And the question of health is the question of governance and leadership. Because once we leave it to patronage, then standards are put below. Once we leave it to 48 different employers, these healthcare practitioners are being demeaned heavily. So before we speak about anything else in the gaps, the first gap that must be addressed is the formation of a National Health Commission, which I know he has championed for before. And it's time that all healthcare practitioners, all of them, unite in one voice and talk about the establishment of a National Healthcare Commission that looks into their welfare, that looks into their earnings, that looks into their dignity. Because you find, for example, a nurse, is trained to specialize in mental health care. Yes. But then you find them redeployed at a county to a pediatric section, whereas this nurse would be effective at a mental health care section. What are we doing? We're having misplaced what?
So what would the formation of that commission achieve? Because from what you're citing, we have a structure on how our healthcare system should work. We have the software. We know how, the operationalization of it. But then you also have the humans. And I think it is the human capital in this aspect that is failing us, because even if we form a commission and then we have Dennis becoming the governor of that county, and then the appointment or the chief officer health is based on what you're saying, patronage and political endearment, you're still going to have the same problem. So in a manner of speaking, is the devolution aspect by itself the problem, or is it the people that we have entrusted, beginning from the CS Health all the way down or all the way up, depending on how you look at that pyramid?
You know, something interesting. I would not want to look at personalities.
Right.
For one reason, that personalities often change. All of us in this room are different in our own ways, and leadership, as we see it, is different. I look at systems, okay? And as long as we don't have a system that is productive, then we are expecting a result. It's just like saying, development is by empowerment. Empowerment is by Harambe. It's stupid. Where a CS carries 10 million to Harambe and says this is empowerment. That is stupid, because that's not a system. It can't create people. Systems create people. Okay? Now, if you come back to this very question, health as a question can be tied into 3 or 4 sections, in my view. One, preventive health can be handed over to the county. They have the CHPs, they have the CHVs.
Yep.
This country, and Dr. Miskela knows this, we wait for the patient to show up, and then we start talking about health at the time that the patient shows up for diagnosis or for screening. What are we doing? By the time the patient is showing up, already something is broken. Okay? One thing that we should focus on, just like Cuba is doing, focus on preventive health. If we focus on preventive health, we're going to cut down the cost of treatment by more than 50% of our budget that we're talking about. And that focus on preventive healthcare should be given to the what? To the counties. As CDSA, what we do is we do a lot of public education on different issues. Like just the other day, we were doing something about respiratory illnesses in CIO. And we find out that if a lot of effort was placed in preventive health and handed over to the county specifically to continue it, give them some little money, let them do education. Education is easier than treatment, because treatment, we need standardization.
Yep.
Health is a national security question, just like education for me, just like transport for me. It is in this country where we're having a free market, where transport is in the private hands, okay? Where health is a business. Where education, we have private schools where some children are dying in those private schools because of lack of standardization. Now, unless we standardize and agree that preventive to party counties, but on the issues of treatment and the issues of healthcare professionals handling, let's leave it to the national government. The issue of infrastructure, as you said, counties are messing a big time. There are some of them which are doing very well. You've seen like Kakamega has put on a level 6 facility, which of course they're handing over to the national government. Beautiful. And many more level 6, level 5s, level 4s, which they've built. But the question is, if you go to some counties, can I surprise you, for example? Sia County, this is year what of devolution? Year 13?
14.
Year 14. There's no renal section. Renal unit. There's no ICU.
In CIO.
In CIO. I was shocked.
The whole of the county.
The whole of the county. I was
But
shocked.
I saw they launched a morgue the other day.
I was shocked.
Guys, it's Daktari. Daktari.
Yeah, it was everywhere.
Yeah.
Yes.
Daktari, when you look at healthcare, one of the key things that